Welcome to the IRS Education Webinar on Neurological Complications after TEVAR Procedures. My name is Hilary Grocott. I'm a professor of anesthesia here at the University of Manitoba in Winnipeg, Canada. I will serve as the moderator for today's webinar. Now, before I begin, I'd like to go through a few housekeeping items with the following slides. Firstly, this webinar has received no commercial support. The webinar is in compliance with the ACCME requirements and policies. Importantly, after the webinar, you will receive an email with information about obtaining your AMA Level 1 CME credits. I'd also like to extend an invitation for you to join us in March for the 2022 IRS annual meeting. The deadline to submit abstracts is November 12th. Also keep in mind that all of the IRS annual meeting recordings are available for viewing now through an on-demand access technology. After this webinar, join the speakers in the IRS Doc Matter community to continue the conversation. Again, a recording of this webinar will be available to IRS members by the end of the week. At the end of this webinar, there'll be an opportunity to submit questions, and please use the Q&A button below. I'd now like to introduce all of the speakers now, after which we'll hear their short lectures. Our first speaker today is Thomas Lindsay. He's a professor of surgery and a member of the Division of Vascular Surgery at the University Health Network at the University of Toronto. He's a clinician scientist whose research is focused on advancing endovascular interventions for thoracoabdominal and juxtarenal aneurysms, as well as novel therapies to prevent post-interventional spinal cord complications. He's going to speak to us on recent surgical advances. This will be followed by Dr. Hamdy Awad. Dr. Awad is a professor of cardiac anesthesiology at the Ohio State University Wexner Medical Center. He trained in Europe, in Egypt, UT Southwestern, and the Cleveland Clinic, and now runs an NIH-funded lab at Ohio State that uses preclinical small and large animal models to understand the fundamental mechanisms of spinal cord injury after both open and endovascular approaches to aortic diseases. He will be addressing paralysis after TEVAR. Following that, we'll hear from Dr. Sujatha Bhandary, who's an associate professor in the Department of Anesthesiology and chief of the Division of Cardiothoracic Anesthesiology at Emory University in Atlanta. In addition to her interests in cardiac anesthesia and aortic surgery, she also serves as an examiner for the American Board of Anesthesiology and a member of the Committee on Cardiothoracic and Vascular Anesthesia at the American Society of Anesthesiologists. She will be addressing the issue of stroke after TEVAR. And last but certainly not least is Theodore Wein. Dr. Ted Wein is an assistant professor of neurology and neurosurgery at McGill University in Montreal. He works there at the Stroke Prevention Clinic at McGill University Health Center. He trained at the University of Vermont College of Medicine, following by which he had a residency at McGill University, and also has fellowships in stroke and neurocritical care from the University of Texas at Houston, as well as neuromuscular diseases at the University of Michigan. His numerous publications include those related to trials on stroke and stroke recovery. Importantly, he is also chair of the American Heart Association's International Stroke Conference's annual meeting entitled Stroke in the Real World, which brings the latest advances in stroke care to practicing healthcare workers. He is going to be specifically addressing the topic of what the role is for neurologists in stroke and paralysis after TEVAR. I will say it's a great pleasure and an honor to have this elite multinational group of experts with us today to address neurological complications after TEVAR. Let's now go to Dr. Lindsay's talk.
Mr. Chairman, ladies and gentlemen, today I'm going to share with you some recent surgical advances in TEVAR. These are my disclosures. As you all know, TEVAR started with deployment of grafts in Zone 3 and limiting them to Zone 5. But as advances have occurred, we're now landing in Zone 3 all the way to Zone 0. And this has induced a new series of complications, including strokes, spinal cord ischemia. And I'm going to discuss not only those, but some new devices in left subclavian for the left subclavian and some new repositionable devices. Now, in 2021, the indications for TEVAR have expanded greatly and include the thoracic aortic aneurysms of 5.5 to 6 centimeters, acute traumatic aortic disruption, type B aortic dissections, acute thoracic aortic syndromes like intramural hematoma and penetrating ulcer, and prior to advanced fenestrated thoracoabdominal repairs. Now, stroke has long been known to be a complication of TEVAR, and while we always thought it was atheromatous debris or secondary to coverage of the left subclavian or the standard causes that were hemodynamic or occlusive disease, we now recognize that air emboli are a major problem. And here you can see a TEVAR graft that's been deployed with small bubbles that can go up and occlude arteries in the brain. These sometimes lead to silent brain infarction, and they're seen on DWI MRI. And they've been associated with worse cognition and increased risk of dementia. Recently, the STEP trial identified cerebral microbleeds after TEVAR cases. They looked at 91 patients who had grafts deployed either in between Zone 0 and 3, and they flushed all the grafts with CO2 and saline and did an MRI within 7 days. What they found is that approximately half the patients had DWI lesions. Most were in the left hemisphere, but they were found in all hemispheres, and many of them were bilateral. They were more common in urgent cases, and they were more common if they were doing arch or branched cases compared to tubular grafts. And they were more common in the larger cases. So despite CO2 and saline flushing, cerebral microbleeds occurred, and they probably are associated with some long-term consequences, and we need new strategies to develop and prevent these. Now, what about the role of left subclavian artery coverage? Because we all know that if you cover the left subclavian, you reduce flow up the left vertebral artery, and if the left vertebral artery is dominant, that can lead to stroke. And indeed, in the mother registry, if you covered the left subclavian without revascularization, there was an incidence of about 9.1% of stroke. It reduced to 5.1 if you covered and revascularized the left subclavian. But if you didn't cover it, the stroke rate was only 2.2%. So when should we do it? Well, when the left vertebral is dominant, when the right is atrophic or absent, and if the the vertebral goes right into the posterior inferior cerebral artery, or if it's been an inflow for the heart for coronary revascularization. This can be done either through a surgical bypass, a transposition, or a power wire, which is shown on the right side here. If you cover the left subclavian with a TEVAR, you can either laser a hole or put a power wire through here to burn a little hole, place a graft in here, and reperfuse the subclavian. Industry has got on board, and there are new grafts which have been designed and published on, but none are yet FDA approved. Now, what about moving on to spinal cord ischemia? We all know that that's a significant risk if you cover more than 15 centimeters, if you have collaterals that are ligated by previous aortic surgery, and if you have compromised internal iliac artery perfusion, and you cover the critical region between T10 and L1. Usually we treat with spinal cord drainage, maintain blood pressure and hemoglobin, and treat with some medications. But there is now preoperative spinal artery embolization and potentially a role for hyperbaric oxygen rescue. Now, the concept of the collateral spinal cord network was initially published by Greep and his group, where they ligated segmental arteries to the spinal cord and noted that there was increased perfusion in collaterals after 5 days. They also did experiments where they embolized spinal arteries in pigs and then went on to simulate thoracoabdominal repair and observe the histologic and functional spinal cord injury. And this was prevented if they did preoperative spinal cord embolization. This has been tried in humans and published on by Branzina, who published 54 cases where they did preoperative embolization that you can see here on the left of spinal arteries, and they had no episodes of paraparesis or paraplegia. This is now being subjected to a trial, the protocol of which has been published in the British Medical Journal, and you can see the patients will be randomized 1-to-1 either to MIS-ACE or the control arm, and will have long-term, both short and long-term outcomes of this. The other controversy that's arisen is, should you drain CSF in all of your patients? And Oderich has been somewhat outspoken about not draining all the patients in order to prevent complications such as epidural hematomas and subarachnoid hemorrhage. He recommends that only selectively in type 2 or type 3 repairs or coverage should you use a CSF drain, but you've got to be able to place a rapid rescue drain within an hour, which can be a challenge in some centers, including ours. We use routine drainage for these patients that's placed under imaging guidance in order to try to reduce complications. We minimize the amount of CSF we drain, and we do it for 48 to 72 hours using this type of a setup that I'm sure many of you are familiar with. Now, there are also repositional devices which are coming, and these allow more accurate deployment so that you can actually get a better seal in your proximal and distal areas. And you can see that this is a 2-stage deployment, and that helps with that. You're going to see these advances in your operating room soon. So in summary, TEVAR is a standard of care for many patients with thoracic aortic pathology, and it is increasing. Stroke does occur between 2 and 5%, and although air and atheroembolization are possible causes, we now have methods to prevent these. We definitely preserve left subclavian flow to maintain cerebral blood flow, either by surgical or endovascular means. And to prevent spinal cord ischemia, we have a multimodal approach, including maintenance of blood pressure, hemoglobin, and pharmacologic agents. We still do drain CSF, but there may be a role for selective drainage. The role of spinal artery embolization is being tested in a randomized trial. And as I say, new repositionable devices are likely coming to an operating room near you, which are hopefully going to improve our outcomes. I'd be happy to entertain any questions. Thank you.
Hello, my name is Hamdy Awad. I'm an associate professor of anesthesiology at the Ohio State University, Wexner Medical Center in Columbus, Ohio. And today my talk about paralysis after endovascular aortic aneurysm repair. This is my financial disclosure regarding the talk. And my objective is to talk about the historical perspective of ischemic spinal cord injury and paralysis after aortic aneurysm repair, the clinical guideline for spinal cord protection, current anesthetic and surgical protective strategy to prevent paralysis, difference in the pathophysiology of ischemic injury in open and endovascular aortic aneurysm repair, and finally, the future direction. William Osler, the father of Western medicine, mentioned there is no disease more conducive to clinical humility than aneurysm of the aorta. And anesthesiology and the surgeon who deal with the aorta know the meaning of this statement. In 1912, Alex Carrel won the Nobel Prize in Physiology and Medicine, predict that the main danger of the aortic operation does not come from the heart or from the aorta itself, but from the central nervous system. And this statement is still true today. Alex Carrel is the father of vascular anastomosis and was on the cover of Time magazine twice. The first reported spinal cord damage after aortic surgical repair done by Conard and Hartley in 1951, which was also the first reported complication of paraplegia after aortic aneurysm surgical repair. And the prediction was true 40 years later. In 1994, the first documented cases of transluminal placement of endovascular thoracic aortic stent published in the New England Journal of Medicine by the team from Stanford. The same team followed up in 1998 with 102 patients with thoracic aortic stenting and document 3% plus or 2% for paralysis, and the stroke rate was 7% plus or minus 3%. However, the endovascular aortic leak was up to 30%, and this might explain the low risk of paraplegia. The first published report of the delayed onset of ascending paralysis after thoracic aortic stent came from Cleveland Clinic, published in the Journal of Vascular Surgery in 2000. If you look 60 years later about the risk of paraplegia after open and endovascular repair using a Crawford classification, published from the Aortic Center of Excellence by Christian Etz, if you look at type 2, the open repair and endovascular open repair have up to 22% of paralysis and endovascular up to 19% of paralysis. If you look at the American Heart Association guideline for the diagnosis and management of patients of thoracic aortic disease and recommendation for spinal cord protection during descending aortic open surgical and endovascular repair, CSF drainage is class 1B for both open and endovascular repair. If you look at the reference in 360 pages, there is 3 references regarding open repair of randomized controlled trial. And there is no reference regarding randomized controlled trial for endovascular aortic aneurysm repair. There is a position paper in 2015 by the European Association for Cardiothoracic Surgery, and they downgrade the CSF drainage from 1B to 2AC because it is expert opinion. And the reason for the downgrading, there are no randomized controlled trials. If you look at the indication for the use of CSF drainage in TEVAR, if you're covering endovascular stenting from T8 to L1, if you're covering a long segment of thoracic aorta, more than 30 centimeters, if you have a compromised collateral pathway in previous intravascular, infrarenal aortic aneurysm repair, or including the hypogastric, or covering the left subclavian artery without revascularization, if the patient develops symptoms and does not have a spinal drain pre-operatively. What about the patient who have a high risk for spinal cord ischemia after TEVAR? Advanced age, more than 70 years, perioperative hypotension, mean less than 70 millimeter mercury, renal insufficiency, COPD, hypertension, and degenerative aortic aneurysm. If you look at the surgical risk factor for spinal cord ischemia after TEVAR, total aortic coverage more than 250 millimeter, concomitant abdominal aortic aneurysm or prior abdominal aortic aneurysm surgical repair, coverage of more than 2 vascular territory, left subclavian artery coverage, procedure urgency, coverage of hypogastric artery, using LL conduit, using more than 3 stents, longer duration of the procedures, excessive blood loss. What about the anesthetic technique for prevention? The anesthesiology can maximize oxygen delivery to the whole body, including the spinal cord, optimize hemoglobin, mild hypothermia, maintain CSF pressure less than 10 millimeter mercury, maintain spinal cord perfusion more than 80 millimeter mercury, and using neuromotor and somatosensory evoke the potential if it's available. What about the surgical technique for prevention of ischemic spinal cord injury? Staging the procedure using left subclavian artery revascularization, minimally invasive segmental artery coil embolization. There is a clinical trial going on in Europe. We're waiting for the result. Temporary aneurysm sac perfusion in some center in Europe. Implantation sequence rearrangement for branched and fenestrated grafts to reduce the risk of paralysis. Finally, I would like to talk about our publication in Nature Scientific Report this year, looking in larger animal model about the pathophysiology of ischemic injury in open and endovascular repair. Our findings document that there is different pathophysiology between open and endovascular repair with regard to the evidence coming from behavior of the animal, histology, imaging, MRI, and metabolome data. Our publication, our result also calling for development of new therapeutic tailored to 2 distinct pathophysiology between open and endovascular repair. Thank you.
Good afternoon, everyone. My topic is stroke after thoracic endovascular aortic repair. My name is Sujatha Bhandary. I'm an associate professor in the Department of Anesthesiology. I also serve as the Chief of Division of Cardiothoracic Anesthesiology at Emory University, Atlanta, Georgia. I have no disclosures. Objectives include incidence of stroke, etiology, risk factors, diagnosis, and treatment. Approximately 2.9 to 5.8% of patients undergoing TEVAR develop stroke. About a third suffer in-hospital mortality. Etiology is embolic, hemorrhagic, or due to hypoperfusion. A 68-year-old woman with a history of smoking and hypertension presented to an outside hospital with acute chest pain radiating to her back. She was hemodynamically stable. Chest CT demonstrated an intramural hematoma centered at the aortic arch, tracking proximally to the ascending aorta and distally to the descending thoracic aorta with anterior mediastinal hemorrhage. Patient underwent hybrid type 1 aortic arch debranching with staged thoracic endovascular aortic repair. She suffered an embolic stroke after stage 1 debranching of the aorta and developed spinal cord infarction after stage 2 subclavian carotid artery bypass and TEVAR. This is an illustration of aortic anatomy treated with hybrid type 1 aortic arch repair involving debranching of the innominate and left common carotid arteries with staged left subclavian carotid bypass and TEVAR. This also depicts blood supply to the spinal cord. The contribution from left subclavian artery via the vertebral artery supplying the anterior and posterior spinal arteries. MRI demonstrates multiple areas of acute non-hemorrhagic infarcts. There is involvement of bilateral, cerebral, and cerebellar hemispheres, with the largest area in the lateral aspect of right occipital lobe. This pattern is consistent with posterior circulation embolic stroke. MRI images of spinal cord are displayed alongside simplified diagrams of spinal cord with shaded areas representing likely infarction. There are patchy asymmetric areas of infarction at multiple levels of spinal cord involving both gray and white matter between T7 and L1 with a normal appearing C7 and T11. Coming to the risk factors for stroke. History of ischemic heart disease, cerebral infarction, shaggy aorta, pull-through wire use, and intraoperative blood loss greater than or equal to 800 cc. What is shaggy aorta? It is a severe form of aortic degeneration with extremely friable tissue leading to embolic episodes. A novel scoring system called Shaggy score is used to predict postoperative embolic complications after TEVAR. In this study, the risk of embolic complication was relatively high in patients with high Shaggy score. Society of Vascular Surgery created clinically oriented risk score model to determine the risk of spinal cord ischemia. There are several predictors of increased risk of spinal cord ischemia as shown in this table. Interestingly, 2 predictors decreased the risk of spinal cord ischemia. Cases from high volume centers and GFR greater than 60. High volume and concentration of contrast may have a role in stroke. Contrast-induced neuronal injury may also be dose-related. If patient develops new onset weakness or if you witness a stroke, please activate stroke code. Time is life. Stroke is a devastating complication. Please involve stroke team early. Embolism is considered as a major cause of spinal cord injury. Let's review some MRI findings. When the MRI findings are asymmetrical, they are classified as sporadic or focal. Sporadic means multiple asymmetrical high-intensity foci involving 3 or more segments of the vertebrae. Focal means asymmetric high-intensity foci limited to 1 to 3 segments. Diffuse refers to symmetric distribution. MRI is capable of demonstrating the exact area of infarction. Therefore, MRI may be of value for investigating the etiology of spinal cord injury. Here is another paper discussing the value of MRI in diagnosing postoperative spinal cord ischemia. Several MRI images along with diagrams showing areas of infarction. Coming to the treatment of stroke, fibrinolytic therapy using tissue plasminogen activator is an option. Mechanical thrombectomy is recommended in acute ischemic stroke patients with large vessel occlusions if intravenous thrombolysis is contraindicated. This concludes my talk,
and I thank you for your attention.
Hello, everybody. My name is Ted Wein. I'm a stroke neurologist at McGill University, and I'm here to partake in this panel discussion on the role of the neurologist in the management of stroke and paralysis after TEVAR. These are my disclosures. I sit on the steering committee of the Heart and Stroke Foundation of Canada, and all of our stroke best practices are available at strokebestpractices.ca, should you care to look at them, where many of the therapies I will discuss today are available for you. The neurologist's role is essential in post-TEVAR procedures, predominantly immediately after the procedure. If there's any neurological sequelae suspected, early involvement is essential. Majority of strokes may happen within 30 days. However, many happen within the first 24 hours. If stroke is confirmed, then time is of the essence. Time is brain, and establishing whether patients are eligible for either IV, TPA, or mechanical thrombectomy is essential. Some limitations to the TPA are its difficulty to establish the time of onset, frequent concomitant use of heparin, as well as the presence of various CSF trains, which would be all contraindications for this therapy. In addition, individuals' bleeding risk factors may be an issue. In addition to that, many argue that the stroke from a TEVAR procedure may be due to aortic arch calcified atheroma, and the TAVI literature would suggest that perhaps TPA is not as beneficial in a calcified plaque, which is understandable. In addition to this, in terms of spinal cord ischemia, frequently the causes of hypoperfusion, this may be to occlusion of an intercostal artery or the development of an aneurysm that may cause a compressive effect leading to hypoperfusion. The second therapy available would be mechanical thrombectomy, which I will review in the next several slides. The therapeutic time window for IV TPA must be done within 4.5 hours. All guidelines around the world suggest that whenever stroke is suspected, imaging by CT scan of the brain to rule out hemorrhage, as well as a CT angiogram of the intracranial and extracranial circulation, is essential in order to establish what therapies may be offered. In individuals who are 4.5 to 6 hours and have a large vessel occlusion, which I'll define in the next slide, they would be eligible for mechanical thrombectomy. Now, the mechanical thrombectomy window has widened in the last couple of years, and now we have in select patients benefit of mechanical thrombectomy in individuals up to 24 hours. And I will review who is potentially eligible and how. So first of all, you have to have a large vessel occlusion. This means you have an occlusion of the distal internal carotid artery, as well as the proximal middle cerebral artery called the M1 segment. As an example, on a routine CT angiogram, it's quite easy to see on the CT scan with contrast that there's occlusion of the right M1 segment. The M2 branches are over here, and these distal branches not labeled are M3. The initial catheters were not able to access these distal branches, and therefore we really focus on this area where the majority of almost all of the studies have evaluated efficacy. The M2 segments are also potential targets, although have not been formally studied in a randomized trial. One may also evaluate the basilar artery for mechanical thrombectomy as well. Most importantly, to extend the time window up to 24 hours is the need for perfusion imaging. This software called Rapid Software establishes two things for us to make our decisions. In purple, we see area of core infarct. This is non-salvageable brain tissue. And in green, we see salvageable brain tissue. When there is a mismatch ratio here, showing more salvageable tissue than core infarct, then we can proceed with the procedure. Just to give you an example of the number needed to treat in order to be discharged home, we can see here that it ranges from anywhere from 3 to 7.4. So quite an effective therapy that has a huge impact on a number of individuals. Outside of acute medical therapies, there's standard therapies such as admitting patients to stroke units. Stroke units are highly specialized units of an interdisciplinary team of dedicated people that only see stroke. It's key. Early mobilization, aggressive treatment of infection and fever, strict glycemic control, and IV hydration as one aspect of care. Not one of these things stands out as the unique reason why stroke units work. In addition, optimal patient positioning and correct bladder care and preventing urinary retention are quite important in order to try to prevent the development of spasticity, which is also associated with early on fever. Spasticity is the leading cause of disability and predictor of poor outcome in our patients. Just to give you an example of how effective stroke units are, in the study by Kalra and colleagues, mortality decreased by more than 50%. More than 50% more people are discharged home, and the length of hospital stay is diminished. On average, in meta-analyses, stroke unit care will reduce mortality by 20 to 40% and improve functional outcomes by around 25 to 35%. In addition, another aspect of care is cerebral perfusion pressures, optimizing that predominantly in spinal cord injury, but also in ischemic stroke of the brain. For brain ischemia, it's been shown that individuals' sweet spot is mean arterial pressures between 100 and 140, where if you're outside of this paradigm, you have a greater mortality rate. Finally, antiplatelet management is quite important. The IST and CAST trials of 40,000 people given ASA 160 milligrams to 300 milligrams show that for every 1,000 patients we treat, we can prevent 10 deaths. Well, dual antiplatelets have really come into vogue right now following stroke and minor stroke in TIA. It's important to note that they have not been studied in people with moderate to severe stroke or completed stroke, and not studied outside of the 24-hour time frame window. I think it's reasonable to consider this if you're worried a patient is unstable, but I cannot provide you with evidence-based medicine that that's what should be done outside of this 24-hour period or in individuals with moderate to severe stroke. I'd like to finish up with the identification of spasticity also done in the unit. Spasticity is the #1 predictor of poor outcome and poor motor recovery in our patients. Our physiotherapist several months ago texted me a picture of this individual with a adducted shoulder, a flexed elbow, a clenched fist. His thumb was stuck in his palm. When they tried to stand him, 2 people needed to hold him up. They couldn't get his leg. It would go into flexion, so they were trying to push it down. And you can see his foot wouldn't even go flat here also. very poor prognostic signs in this individual. But I also want to point out that frequently spasticity may be masking underlying function. This gentleman's daughter happened to be a physiotherapist, and we went ahead and applied botulinum toxin therapy to decrease the spasticity. And while this is not a very common occurrence, it does emphasize how spasticity masks function. And this is what happened after we injected him. So this is 2 weeks after the injection. You can see that he's, by decreasing the tone, we've been able to unmask function in the lower extremity. What was going into a flexion response and being completely plegic before is now able to move on its own. And if we look at the upper extremity here, I want to point out that that clenched fist with that thumb and palm deformity that he had, when we paralyzed the mother and modified spasticity, we were able to show that we can unmask function. So there's a lot of things you can do by early involvement with neurology and acute stroke team. And I look forward to I look forward to answering any of your questions. Thank you very much.
Well, thank you very much, Ted, Sujatha, Hamdy, and Tom, for those great talks. They were short, concise, right to the point. So at this point, I'd like the audience participants to put some questions forward in the Q&A button in the chat feature below, and we'll address those as they come in. One of the overarching questions that I would like to have addressed by each of the panelists is this concept of a specialized team that looks after these TEVAR patients. Meaning, is this for any anesthesiologist? Is this for any vascular surgeon? Is this for any neurologist to look after, or does it really need to be a team of experts looking after these patients? Maybe Tom, you want to start with that?
Sure. I guess what I would say is that, we're a tertiary referral center. So obviously we do a fair bit of TEVAR for all of the indications that I talked about. So all of the vascular surgeons participate in standard TEVAR. Obviously, when we're doing arch and branch and fenestrate cases in the arch, that's a little more selective. But what I would say is that this begins with, assessing of the patient preoperatively. Before COVID, all of our patients would come and see anesthesia, so they would be very aware of them. They're getting the same kind of interview, but not in person now. And then, of course, the planning of the procedure, the planning of the anesthetic, and the post-operative care is critically important. And so we have most of our anesthetists do these cases for the straightforward ones, but certainly when we're doing branched and arch cases, we have a long chat about those ones beforehand, because there are many different things that we do intraoperatively, including monitoring of the brain, as well as we use hypotension for deploying the grafts and whatnot. We have not been using shields or any of the cerebral protection devices for standard TEVAR. I know they haven't been shown to be effective in TAVI, but we have not used them. But I would say the multidisciplinary approach, when you have a problem, you got to get we have code stroke at our hospital. We call it code stroke. We get the stroke team involved early, and that's often of benefit. So I think that the whole team approach is in fact particularly important, right from the planning of the procedure to the doing of the procedure to the post-operative care.
Great, thanks, Tom. Hamdy, do you want to chime in there and say a few words?
I think, thank you, Hilary. I agree with Dr. Lindsay. Team always work, and behind my picture, the football team, you always need a team, and team is provided better care than a single individuals. And start with the pre-op assessment, the surgical technique and the skills, the vendors who's bringing the technology, and post-op management, including the ICU team and the critical care intensivist. It have to be a closed loop system to improve the clinical outcome. And this is a high-risk procedures, high-risk cases, and the stakes are high, including the spinal drain, hemodynamic, neuromonitoring, and even including the neurologist in the institution for early on. I think the team approach is always winning.
Great, thanks, Hamdy. Ted, I'm going to just address that question to you, or maybe even answer for you. I mean, you've already told us that a neurocritical care unit, a stroke team, is so vitally important. So I think you would probably agree with what the others have said so far.
Yeah, I absolutely agree with everybody has said, and I would really want to reinforce it. There's trials that looked at stroke patients in general medical wards versus stroke units versus a neuro ICU. And consistently in all of these studies, the specialized stroke unit, even compared to the neuro ICU, patients always did better. And I'm going to correct. I'm going to paraphrase what Dr. Lindsay said, because our team gets angry when we call a multidisciplinary approach. I think all the healthcare providers like to call it an interdisciplinary approach, and that we really need to work in unison as a team, with everybody being just as important as each other. But the literature consistently, and that's why I showed the slide on the benefit of stroke units, it really doubles the benefit to our patients.
Great. In the interest of time, Sujatha, just you have a final comment on that question. I want to get to the audience questions now.
I do agree that it has to be multi or interdisciplinary, and these are super high risk cases. And again, would like to emphasize that in different institutions, who places the drain, and is it IR, is it anesthesiologist, is it asleep, awake? These are all variables. So I think it would be really having a consistent, like a team would be really beneficial.
Great. So that's a great segue, because we've had a number of questions come in regarding placement of the CSF drain. So maybe either of you or Tom or Ted can chime in here, but one of the questions that's come up is, should this be placed using a landmark approach, or should this be in interventional radiology? And if so, who does it? Other issues that have been raised are, should aspirin be stopped? Should there be any other changes in these patients' medications? So let's just deal with the IR issue.
Well,
Ted, do you guys use IR?
We use IR.
Okay, Tom?
Yeah, we use IR. So what we do is, if we're putting in a spinal drain, we put it in, the anesthetist and the anesthesia and our IR people put it in under image guidance in the operating room. So in other words, we turn the patient, we usually put it in with the patient awake. We turn the patient on their side. Some anesthetists want them sitting up. It's easier on their side to get a good imaging, because many of these people, they don't have normal 20-year-old spines. These are 70 and 80-year-old spines. So getting in between the vertebral in the vertebrae is critically important. And the fewer passes you do.
Is that in a hybrid operating room with good fluoroscopy? Okay.
Yes, that's in a fully dedicated, that's the room that we will do the case in, which is a full angio suite in the operating room. And for our open cases, even though we're not talking about that today, they go and have it put in an IR the night before.
Yeah, same with us. Sujatha?
In our institution, it's all placed by anesthesiologist, and that is done asleep in Emory University. And when I was training, when I was training at Cleveland Clinic, it was always awake, and we placed it ahead of time. And then we had a shift in practice. Maybe Dr. Awad can add to this. Depending on high-risk cases, people may be triaged to go to IR, and if it is not a high risk, then awake with
done
by
anesthesiologists.
Hilary, this is a great question. We published a paper in Anesthesia and Analgesia looking to 15 cases where the anesthesiologist failed or unable to obtain a spinal drain by landmark, and the fluoroscopy succeeded. And this is an issue in flux, and it's very dynamic, and it creates a lot of emotion between our groups. And I feel like the even the landmark play a role. However, the IR, when I go and see how technically the IR help us putting the drain, I'm leaning toward the using fluoroscopy. It gives you a better performance. It minimizes the complication, and you'll be sure you can see the tip of the catheter approximately at T10. This means you know you have a functional drain, spinal drain in the unit, and instead of going blindly, and then you have non-functional epidural or spinal, and then you wanted to deal with the complication of the failure of the replacement.
Yeah, I would think if one sort of took the pulse of the North American situation, I hear what you're saying. I suspect that the majority of centers are not using IR, but I think they're probably changing. But it does present those logistical issues, doesn't it? I mean, Tom has a great operating hybrid room with great imaging there. Other centers would mean, transferring patients from interventional radiology, and that adds time, expense, logistical challenges. So I think we'll have to probably wait for more data on that to see if it really makes a difference. I suspect that a lot of people, for simplicity's sake, would rather just do it with landmark technique. What about the aspirin question? Do you stop aspirin, Sujatha?
No, we do not. Aspirin will be continued. Yeah.
Okay.
If I could just chime in on that from
please,
the neurologist perspective, I apologize. So we've done a lot of work showing that individuals who require their ASA for cardiac or prior stroke, that stopping that ASA for a week before actually has a 2.5 to 3% stroke rate in individuals.
Right.
So a strong reason why it should not be stopped. Clopidogrel, a little bit of a different story if they're on combination. But absolutely, I encourage people, based on our data, at least not to stop the use of ASA.
I think that's a really great point. I think we overplay the importance or the risk of small dose aspirin with lumbar drains. I don't think it really significantly adds to the problem. As you pointed out, it might be a significant help. Tom, I'm going to address a question to you about subclavian revascularization. And I'm going to kind of, sort of paraphrase a question that's come in. When you do, which patients do you select before you go into the operating room that we are going to do carotid to subclavian bypass? Do you do that at the same setting beforehand? Who do you choose?
Well, so first thing is that as long as if the landing zone is going to be in zone 3, which by definition is distal to left subclavian, then I don't obviously do any kind of revascularization. A patient comes in with a ruptured thoracic aneurysm, they don't get subclavian revascularization, even if I have to do that at least before I've done the TEVAR. Now, if I'm really worried about it and on the pre-op CT, I see that the left vert is large, I will do the TEVAR, and then right then and there, just once I finish the TEVAR, I'll do a carotid subclavian bypass. Carotid subclavian bypass, as I'm sure all the anesthetists know, it's never that short little procedure that you'd like it to be. So that's part of the reason why these new grafts are coming online. So you'll be able to land more proximally and then just revascularize the left subclavian. So we do have, there's surgical techniques as carotid subclavian, but we often, for us, it's not that difficult we use a power wire technique where what I showed you, we just make a hole through the TEVAR and then open it slightly with a cutting balloon and then put a stent there and seal it in the left subclavian. So you can revascularize that. That might take 45 minutes or an hour, whereas a carotid subclavian will probably take about an hour and a half or 2
And you're
hours.
using a brachial artery approach to that catheter?
Yes. Yep. You can use a brachial artery approach. You can do a nice little cut down just right above the elbow and usually in a thin place in the patient, and it doesn't take that long. I find that to be very helpful. But I think it's extremely important that you look at your pre-op imaging. If I'm doing an elective TEVAR case and I'm thinking I might cover the left subclavian, well, I often do a carotid study which has vertebral Doppler as well as I know what the blood pressure is in each arm, so that way I can maximize their cerebral perfusion.
Great. There was one question that came in regarding sort of going to those issues that I talked about of having a team and expertise there. Do you think that there's a minimum number of TEVARs that a center should be doing in order to maintain that level of expertise? It's a very controversial question. Hamdy, why don't you say a few words?
I think it's really, Hilary, it's a minimally invasive procedures. However, it's a very complex procedures. I want to go back to the subclavian, and we just published a paper about the dual role of the subclavian. When you do the type 1, you wanted to prevent embolization. On the other hand, when you put the stent in the thoracic aorta, you need to increase the perfusion pressure through the subclavian artery to the anterior spinal artery. This means all of a sudden the blood supply or the dual rule, preventing embolization in stage 1 and in stage 2, you increase the perfusion pressure to, and I think it's these cases, there was a call in Europe for regionalization of the cases. However, the economics factors and the hospital and the distribution of the cases around the country. However, having a referral center will improve the outcome. We know that high volume center in any procedures have a better outcome.
Great. Sujatha, let me ask you a question. So when you are managing a patient in the intraoperative period and post-operatively after TEVAR, I often get the question, why not just increase the blood pressure and they don't need a lumbar drain, just increase spinal cord perfusion pressure by increasing MAP. What are your thoughts on that?
I would say blood pressure, yes, definitely increasing the blood pressure, increasing the perfusion, I agree. And if we are thinking in terms of the difference, and if you are trying to bring down the spinal, like removing the spinal fluid and increasing that gradient, allowing to improve blood pressure, I'm in favor of that. But I would be really curious to know from other institutions, what are their thoughts? Because I would do both, increase the mean arterial pressure and drain the fluid.
Yeah. Hamdy?
I think, Hilary, now we know that the pathophysiology of the two diseases are different, and the CNS produces its own lactate. This means the systemic lactate does not cross the blood-brain barrier and go to the CNS, and the neurons and the oligodendrocytes need lactate. I don't know if draining the CSF, preventing substrate, this is just a hypothesis. I'm not against the drain, but I'm just saying that the newer research in our group and others showing us that they are two separate diseases, and you might increase the substrate for the perfusion for the neuronal cells, the neuron and the supporting system, the glia and the oligodendrocytes.
So some theoretical reasons, perhaps. Ted and Tom, do you want to think about that as well? I mean, we know drainage. I mean, the evidence supporting drainage is fairly soft, and it's quite old, actually. And I know there are centers that have chosen not to do spinal drainage and only put it in as a rescue technique. Again, the evidence for that is soft as well. But in the interim, enhancing that blood pressure. And Ted, I wanted you specifically to answer the question about what the MAP should be, because I was surprised, maybe encouraged by what you said about stroke, keeping those MAPs greater than 100. And sometimes in these aortic disease patients, that's often a challenge, particularly in the open cases. But what do you think the blood pressure should be to help the spinal cord?
Yeah, so first of all, I mean, the graph I showed before was looking at mortality in the average stroke patient coming in, showing that you had double the mortality if your MAP was less than 100 or greater than 140. So people in the 100 to 140 range seem to have the best prognostic outcome in terms of mortality, not necessarily in terms of function. I do favor having the MAPs at around 110 to go back to because inducing it higher than that is frequently challenging. To go back to your previous question of spinal drains, we're relatively split here at McGill, and we have various approaches based on the anesthetist and the vascular surgeon involved. And I would say probably 2/3 get a drain and 1/3 don't get a drain. I was trained at the University of Texas and the University of Michigan, and we tended to do drains. I think it's looked at a little bit less favorably by some of the neuroanesthetists I've worked with here in Montreal. I do think from a physiological perspective that it makes sense to do. I do agree openly that the data supporting this is limited. However, we don't really have a lot of other great therapies for spinal cord ischemia. And the question is there any significant negative that will come from this? And I think we have to give our patients being every fighting chance. As a neurologist, sometimes it's depressing to see paraplegic and quadriplegic patients, and I try to do whatever I can, either based on clinical trials, based on physiological mechanisms, to try to maximize patients' function. And I think it's well worth the trial personally, not based on a randomized trial.
Great. Tom, can you just answer one specific part of that? Are you a hands-on person in the ICU after these patients are dropped off there? Are you involved in the blood pressure decisions?
Oh,
and
yeah.
What should it be?
All right, so let's break it down. For a standard TEVAR, if you're going to cover all the way from the left subclavian and you're going to go right to the celiac. So my evaluation first of all, I'll look at the CT and see how many intercostals there are. So we've taken up doing spinal artery embolization. So I will embolize them preoperatively and wait 2 weeks. About a week before surgery, I look at their antihypertensives, and I will reduce their antihypertensives until I want them to come in with a blood pressure of 140. I don't want my anesthetist to induce them and have see a blood pressure of 100 during the case when I'm worried about it. So I will monitor their blood pressure and let it rise up to 140, maybe even 150 preoperatively. Okay. And then you've got to be, I hate to say it, but you've got to be in the ICU looking after those patients. So we have a joint management situation where we definitely, I go to the ICU, I attend in there in the non-ventilated patients. So a TEVAR patient would generally be non-ventilated, and many won't have a spinal drain. But in the high-risk ones, we will put a spinal drain, but we certainly do blood pressure. We watch them extremely carefully to keep their spinal cord perfusion pressure up, because once you get into a situation of paraparesis or paraplegia, it's hard to rescue them.
Okay, that's so interesting you talked about blood pressure, because one of the questions that has come in is, should we normalize blood pressure before you undergo these procedures? And I'm sort of hearing from you that we don't want normal blood pressure coming in. You'd much rather have it on the high side.
I definitely would rather have it on the high side, because you guys know better than me. There are very few anesthetics that you can give that are, won't lower your blood pressure. And let's face it, patients don't have, there is surgical stress, but you're generally fighting hypotension, and the less of that you're fighting post-operatively, it's easier to decrease the blood pressure in the ICU from my perspective than it is to increase it, because we're giving, we're starting the Levophed, and then we're getting them on vasopressin, and those all have their side effects. So I'd rather be a little high on the way in, okay, and be prepared to lower it if necessary.
I think that's a great point. We have just a couple of minutes left. So what I'm going to do is, firstly, I asked the panelists just to stay on a little bit longer until we get through some of these questions. But for those that need to leave, those participants, I wanted to thank all of these panelists today for really actually great talks. And I think this Q&A session has really added to our knowledge and the innovation that's going on in here. So I'll thank them. We do have a couple other questions, and I'm just going to ask, this is about the post-operative management of a patient with a spinal drain. I want to know what your antiplatelet management is. I'm going to assume, Ted, you're staying on aspirin. If they're on a dual antiplatelet for other reasons, do you reinstitute it while the drain is placed? I want to know what you think about DVT prophylaxis. Do you give them low molecular weight heparin? Do you just put compression stockings on? Those are the nuances that I'm hearing from some of these questions.
So for me, we would use compression stockings usually for the first 48 hours
Okay.
and then switch to low molecular weight heparin. Hopefully the drains are out by then. In terms of the dual antiplatelets, honestly, I haven't thought of it that much because it's more for the cardiac patients than the neurological patients that are on that combination long-term, at least. I don't stop the aspirin to begin with. I would probably restart the clopidogrel 48 hours afterwards or removal of drains.
Yeah, after removal of drain.
Right.
Yeah. And would you give any other anticoagulants apart from the compression stockings, sub-Q heparin?
So I would start the sub-Q heparin 24 or 48 hours afterwards, but preferably when drains are removed.
Hamdy?
I think I want to mention about complication after taking the drain out. We have 1 or 2 cases where you continuously leak CSF and the question of herniation. This means it's very important for the team to follow up and see if there is any continuous leak of the CSF. We continue the aspirin. We don't start antiplatelet until after 24 hours. We publish an epidural hematoma when the patient went to the hospital, left the hospital and came back with spinal epidural hematoma, and we publish in the anesthesiology journal. This means there is a risk of adding dual or triple therapy, and it's a risk-benefit ratio. You have to think about it.
Yeah, I think those post-operative complications are sometimes under-recognized, and I think the same precautions that are needed to place the drains should be in place when they're removed. Is that fair to say?
Absolutely.
Yeah. Yeah, absolutely. So we leave patients on aspirin. We stop the clopidogrel 7 days in advance before we place the drain because our anesthetists are worried about that. For our patients, we don't give them heparin post-op, even DVT prophylaxis. We use sequential compression devices for the first 48 hours until the drain is out. Once the drain is out, we usually, so if the drain comes out at say noon on the 2nd or 3rd day, then the next day they get DVT prophylaxis and it's sub-Q heparin, not enoxaparin. And we try by that point to get them out of bed. Hamdy's right, you've got to be prepared. Occasionally, some of these patients are going to have CSF leaks, and we're pretty aggressive about making sure that they don't leave the hospital with that, because we would do a blood patch if it doesn't stop in 24 hours or 48 hours.
Great. I'm going to take the moderator's prerogative and ask the final question. I want to give me your thoughts on this concept of early versus delayed presentation of paralysis after both TEVAR and open repair. Do you see more frequently, do you see these immediate, meaning patients waking up paralyzed, or is this paralysis that starts to develop 12, 24, 48 hours later?
I can start, Hilary. I think this is, if we look at the data and the literatures, and we think that the immediate paralysis, we're not talking about open here, about the endovascular versus the late, 2/3 of the cases are presenting with the late paralysis. And it's a very dynamic process. And sometimes 1 leg, 2 legs, and then autonomic dysfunction, urinary and stool incontinent, and bladder dysfunction. This means I think it's a very dynamic process and it's not like immediately infarct. And this is the reason why we think that the mechanisms are different. This means in the endovascular sphere, we see more of a delayed paralysis than immediately acute paralysis. However, there is a group in Germany published about 50% of their cases are immediately acute.
Final words from Sujatha.
It's really variable. And I have to be honest with the numbers versus, high volume centers and low volume centers. Likely like earlier that we see. And in one case, in my experience, we did place, that was a case where we had not placed the drain and we placed emergently and the patient recovered. That was very encouraging for me. So that was the moment when I'm kind of pro for the drain.
Great. Ted, last word?
Last word, I have to agree with
Hamdy,
although I would distinguish brain ischemia from spinal cord ischemia. So the brain stuff I tend to see peri-procedure, and the spinal cord probably 1/3 acute, but the majority delayed afterwards.
And Tom,
Yeah,
the-
I would
really
agree.
the final word.
Yeah, most of them are delayed, and in the open literature, it says 10% wake up with it, and the rest develop it perioperatively. So I would say that, but what happens post-operatively is partly dictated by your perioperative preparation. So that's the reason. As soon as we're about to close the final thing where the spinal cord may become ischemic, I say to my anesthetist, okay, it's the last branch. We're doing it now. Let's get the blood pressure up.
Exactly.
And we're very fastidious about that. The one thing, let me just say the last word about spinal drains. There's a recent article in the Journal of Vascular Surgery from October. It's a bit of a selfless plug. It's not from me, but it's from the VQI, which is the Vascular Quality Database, that showed that prophylactic drainage was associated with less postoperative problems and better long-term survival. So it's a retrospective study, but it's sort of about current practice. So I think that's why, in our center, if I'm worried about it, I put the drain preoperatively.
Right. Well, once again, thank you all for this, engaging conversation on neurologic complications after TEVAR. Thank the IRS for offering this webinar to their members. And I'm going to say goodbye from here in Winnipeg, and hope to see all of you in person in the future. Bye for now.
Thank you.
Bye-bye. Thank you very much, everyone.